to damage that optic nerve, which are, optic nerves which are susceptible, may add these things, these factors may add to their damage. So that is why even at night time your pressures have to be under control. So these studies show that, that there are increased diurnal variability in the intraocular pressure is positively correlated with the progression of the visual fields. Another important study by Asrani et al., large diurnal fluctuations in the intraocular pressure are an independent risk factor in the patients with glaucoma. So this was an interesting study which was done. This was a very long-term study. Two group of patients, one with glaucoma, both of them with glaucoma, and both of them apparently had controlled glaucoma. But one group of patients, progressing towards blindness, while the other group of patients, having not progressing much. So when they saw their mean IOP was similar in both the groups, so mean IOP was same, but then why did one group progress towards blindness? And the reason was that, the variability of each patient IOP over the years was significantly higher. So the patients who had significantly higher variation in their IOP progressed towards blindness, while those who had stable pressures did not progress. So definitely these glaucoma fluctuations are a higher risk factor for progression. And for achieving this 24-hour IOP control, prostaglandins are one of the best medications which are available today. So here you will see, this graph is uncontrolled glaucoma without any medication. This may be with timolol, but here there are large fluctuations. Here the fluctuations are not much controlled by timolol also, although you might get a good pressure lowering effect. This is the normal pressure IOP fluctuation or diurnal variation, and these are with prostaglandins. So this is a study which shows effect of timolol, latanoprost, and dorzolamide on the circadian IOP in glaucoma or ocular hypertension. So this is the glaucoma patient having normal IOP, having glaucoma diurnal IOP variation, which is not on medication. So you'll see a large, higher IOP and large diurnal variations. Here we have timolol. Timolol has got good pressure lowering effect, but unfortunately at night, if you see, it does not work so well at night. This is dorzolamide. It has got a pressure lowering effect, not as good as timolol, but it has better IOP control during the night time than as compared to timolol. And this is latanoprost. Latanoprost has a good pressure lowering effect, not only during the daytime, but throughout the day and at the night time also. So for 24-hour IOP control, prostaglandin are one of the best medications that we can be using. So also, last but not the least, my 7th point is patient education. So non-compliance is one of the major problem for preventing blindness. If the patient is, you have prescribed all the medications, but if the patient is not using it regularly, then it's of no use. And major problem for this is one of the major problems. How do we address it? Because why this is important, because there are no symptoms, the consequences are delayed. That is why patient thinks that probably nothing is going wrong with his eyes, and even if he's putting medications, probably he does not feel any difference. So probably there is lack of motivation because of that, and sometimes cost also may be prohibitive. So patient education would also be an important point. So making understand the disease to the patient and also to his relatives, because they are the ones who have to encourage him to take regular medications. This can be done with the help of booklets or videos. Discussion, giving more chair time to the patient and his relatives, at least initially, is also very important. So spend that extra time with the patients initially, so that you make them understand about the disease and the importance of the medication. Proper installation of drops is also important, especially if the patient is having multiple drops. The way the drop has to be put or instilled has to be shown to him initially, because it has a lot of studies which show that even educated patients might be doing a lot of mistakes in putting medication. So teach them how to instill a drop properly in the eye. Spacing of the drop. So if you are on 2 or more medications, the spacing has to be there properly. So say if you are putting timolol at 7 in the morning or 8 in the morning, your dorzolamide or your brimolol, your brimonidine would be probably an hour later. So 3 times brimonidine would be, say, 828 or 939 or something like that, where you have a good spacing of the medications, so you get a good IOP control throughout the day and also throughout the night. So you have to space them properly to get maximum benefit out of the same medication. So in conclusion, we have all these 7 points which are important: patient evaluation with proper documentation, a proper treatment plan in place before you start that treatment, set a target IOP, uh, do a good treatment initiation with the medications that we have discussed before. Prostaglandins probably are the drug of choice, the first line therapy. Combination therapy, of course, would be important if patient is on multiple medications. Concept of 24-hour IOP control is very important. So this is one of the most important points. Just don't think about lowering the IOP, but to have a good 24-hour IOP control is very important. And last but not the least, patient education. So please remember all those points when you are treating a glaucoma patient. And early diagnosis and treatment is the key here for having a good outcome for the patient. Thank you. Yeah. So what the next presentation will be with Dr. Sachin. Dr. Sachin Dharwadkar is Director of Glaucoma Services at Aditya Chotaya Hospital, and he would be talking about OCT and its uses in glaucoma. So I welcome Dr. Deepak Edward. Welcome, sir.
Good morning.
Hi.
Good afternoon to you.
Yeah.
Good morning. Welcome.
Oh,
Deepak.
thank you.
And thanks for the support. And I wanted to remind here to Sachin and Dr. Anupam that Deepak is our visiting faculty, which he has signed up when he was in Saudi, and he still continues. He's our honorary visiting professor.
Well, absolutely. Thank you.
Okay. Okay, Sachin. Sorry for interrupting, Sachin.
Okay, so after that very nice and crisp talk by Dr. Anupam, I would just highlight a few points that we should keep in mind while using the OCT for the management of glaucoma. This will be restricted only to the disc, macula, and RNFL. First of all, I would like to welcome Dr. Deepak Edward. It is a pleasure having him here, and we eagerly await his talk that is to come after me. So without much ado, I start my presentation. I'm just sharing my screen. Is the screen seen?
Yes, yes.
Okay, so we are discussing about the role of OCT in the management of glaucoma. There are certain things that we should always remember about the basics of using OCT in glaucoma care. One is that it is usable for assessment. The technique should be fast, easy to use, accurate, repeatable in its measurements, and capable of assessing progression. So unless all these criteria are satisfied, any machine of OCT cannot be used for glaucoma assessments. It should be minimally user skill dependent and basically heavily automated with the right hardware and the software. And progression assessment being the cornerstone, this feature is a must. So if the machine does not have the software and the hardware for progression assessment, it cannot be used for glaucoma care. Now, as we know, vascular insights that are associated with glaucoma or are independent, they behave very differently on imaging as compared to conventional glaucoma. So, truly speaking, glaucoma can be classified. The only open angle glaucoma and chronic angle closure can classically be followed up with the conventional knowledge of the OCT. The knowledge of OCT angiography has also told us that there are certain things which occur differently in other types of pathologies, like associated high pressure related ischemic damage to the ganglion cells, and that's why we get different patterns of nerve fiber loss there, which you should keep in mind. So having said that, we have to remember that when we use OCTs, all the machines and their hardware are not the same. We have various studies that are being done, and a very few machines have the test, retest, reproducibility, and the intra and inter-test variability, which is good enough to merit its use in glaucoma treatment. So it should be remembered. These figures show you the different the variability in the measurements of different machines as well as the relative resolution of different machines that are available. Scan qualities of machines, the kind of data that they give out, as well as the quality of the images, all differ vastly across the board. And before making a judicious choice of the machine to use, you should be well aware of all these faculties and then make the right choice to use for glaucoma assessment. So this RNFL or macula, which one to follow? Now there are a number of studies that have come and so much of literature that it confuses the reader which is the best parameter to follow. Although all this is basically too much of noise and too less of information, the basic thing is ganglion cell to the optic disc. That is the nerve, that is the axon. It is just one neuron. So seeing different parts of the neuron and judging which is the best to give you an answer is maybe technically a bit inaccurate. So ideally what I would suggest is you look at the whole neuron, which is always more meaningful. Now this is the conventional report of the OCT that we used to get before the ganglion cell segmentation used to take place. Now if you see, this is a slight bit of incomplete information. Now add to this image where you have the imaging of the disc analysis, RNFL analysis and a macula analysis. All these three, you see the entire strip of the neuron ending in the optic nerve head, and this makes the entire analysis more meaningful. So any machine that is not giving you this particular component is not going to be giving you the correct amount of information to make the right decision in glaucoma treatment. Now looking at another example of the same is here. Here if you see, had you seen only the disc and the nerve fiber layer, you have everything in the green, although you had suspected something because of thinning of the inferior temporal quadrant, but clinic on imaging, everything would have been normal. When you see the macula, you definitely make out the notch at the donut, and that's why you can definitely say that what you saw clinically is now reversely correlating to the localized thinning of the NFL as well as the localized thinning on the disc margin. So this will definitely give us a better clinical correlation by looking at the entire length of the neuron of what is right and what is wrong. Now, requirements of an ideal OCT for glaucoma progression. Now, there is very important things that are required if you want to use the machine for progression assessment. One is that the machine should have a very fast tracking system. It should have exact reorientation system to take each and every scan at the same position, as well as it should have an auto rescan placement facility. So all these things are absolutely required, like DMO and vessel track, auto centration and auto rescan. Otherwise, it is very difficult to measure the same point over a period of time and get an ideal idea of progression in glaucoma. Now, that's why the next question, which machine and why? So you need a machine that is fast, having a tracking system. Segmentation of macula is essential. You may not have an independent segmentation of the ganglion cell layer, but you should have an accurate segmentation of the macula, which can be represented usually in a single chart. That's where you can correlate the neuron right from the optic nerve head to the macular ganglion cell. An auto rescan placement, DMO centration and image averaging are ideal, and this give you a superb data which you can correlate and you can use in the management of the glaucoma patients. Now, when to use the OCT? This was another fundamental question. There was a lot of debate and a lot of discussion, but now things in the 2020 appear pretty much very clear with the higher resolution and the faster scan speed. When we see the imaging field continuum, the current status, you see that the visual fields take over somewhere here in between the mild and the moderate glaucoma, and they go all the way till the advanced glaucoma where you have the stimulus size 5. The imaging takes over the left part of this particular spectrum, where the visual field basically is yet to come into play. Again, if you see the prototype RNFL changes here, the RNFL floors somewhere in between moderate to severe glaucoma. So it becomes redundant as it approaches severe glaucoma, where the field completely takes over. Having said that, moderate glaucoma is the time where you have statistical measurements in both the imaging as well as the visual field testing, where you have statistical packages which can analyze. On either side, on the right side of it, that is where the size 5 fields and the 10-2 program take over, you do not have the statistical analysis of progression, but then you have to depend on the values of the mean deviation and maybe a hand-drawn linear regression analysis. Also, in some odd cases, you do have some ganglion cell element that is being left behind towards the end of the glaucoma, although that is not uniform across the board. But that can be definitely used in cases where the RNFL floors faster than the ganglion cell layer. But that is you have to choose wisely on a case-to-case basis. My personal preference would be more of field test as the glaucoma advances more. Now, because of the large range of normal values that we see for the normal distribution of the nerve fiber layer thickness, there can be a significant damage before there is a statistical abnormality that is presented to you by the machine in terms of a color change. Also, there are many cases in which you can have a nerve fiber layer atrophy, but definitely no change in the visual field. That is called as a preperimetric glaucoma. So you can have so many things that are possible even before the initial field defect starts. That definitely tells you that there is definitely a large playing space for usage of OCT if used in the right manner. Now, unmonitored progression on the continuum will cover this much of layer. That is, if you see in the glaucoma continuum by Weinreich et al., almost 2/3 of the continuum is unaddressed by the usage of visual fields. That is where our correct imaging methodology helps us a lot in making the right decisions for the patient, which we'll see in the subsequent examples. So current gold standard approach excludes half of the glaucoma continuum, considering that visual fields or visual field defects are considered as a mandatory gold standard for the detection of glaucoma. Now, how do you use these? These technologies have to be used very judiciously and carefully. You have printouts like this that come at the end of the examination, which is done by the OCT. This is a prototype Cirrus 5000 printout. Here, the important thing is in this image, though you do not have the macular ganglion cell map, we do take it differently or use a setting called as a panomap, where we can use all these three images together and then definitely correlate to come to a better conclusion. Now, important part about this is there are many sequences that have been described in literature, how to go about reading these maps. But only one different thing I would highlight is you have to give all these analysis backseat. Before that, you have to definitely examine the scan quality, what the machine tells you, and the segmentation. So these two are the most important of all the data that is available on this map, even before you start looking at all the other maps. So if this map and this scan quality score is off, then you would not be pretty much using the other data, because it would be giving you actually wrong information. Apart from that, a systematic approach, which is given in many other presentations and many other videos, is usually useful, and then you can come to the right conclusion. Having said that, I would always say that do refer to the ganglion cell and the macula map before you come to a decision. Similarly, this is the Heidelberg. This is the second reliable machine that I have been using for the past more than a decade. And here also we have those similar things. Here the images are pretty much better segmented, and you do have these segmentation lines appearing much more clearly. In case segmentation lines don't appear more clear like in these images, or if you have a doubt, you have to go back to the console and then verify on the screen, and then take it from there whether the imaging modality is accurate or not, and whether you should use the data for analysis. Okay, so all this is the most important image, including the quality scores and the averaging parameters. And once all these are verified, then you can put this TISNET data into perspective and then use it for your management of glaucoma patients. Now, as far as progression is concerned, as I told you, it is a cornerstone of therapy. It is very, very important, and progression analysis is available in the Cirrus machine, which is very much like the event and the trend analysis in the visual fields, where you have the average RNFL, the superior, the inferior, and the average cup to disc ratio. Always remember, with progression, you will have a downslope in all the others, whereas the CD ratio will always go up because of the progression of the cup and disc size relative to each other. Again, having said that, the imaging protocols here are very important. That the R2 should be the preferred protocol, where you have all the horizontal and translational alignment which is taking place, which will make the imaging more reproducible and strict across the board. Apart from that, the quality score should be absolutely impeccable as per the user's recommendations, more than 7, or preferably, according to me, as high as they can get. As far as the same thing in the spectralysis is concerned, we have similar parameters that can be plotted. Each part of the RNFL can be plotted over time, and then you can get a linear regression of all those values, and it can tell you the decibel, or rather the micron change over time, and you can attach statistical significance to that depending upon your knowledge of the accuracy of your machine and the imaging logic that is used according to your ophthalmic society or the glaucoma society guidelines. Similar progression analysis is available with the ganglion cell layer. This is the GC-IPL from the Cirrus, and here also you get two baseline scans similar to that you get in the visual fields, and then you get follow-up scans. Again, I told you the imaging criteria, the imaging modality, and the scan scores are very, very important. And then once you make sure all these are in place, then this becomes a simple what we call as simple interpretation of the slope of the graph and the reading of the statistics of the calculator. So detecting change and measurement of the rate of change are very, very important, and this helps us demonstrate change to ourselves as well as the patient and demonstrate the efficacy of the treatment. Rate of thinning in longitudinal studies till date had been 0.15 to 0.6 microns per year, which is the physiological one, faster in older age, but more than 5 micron loss per year usually in most of the standard machines can be considered significant. Imaging criteria remaining uniform across the board. Remember that statistically normal range is 32 microns, that is from 75 to 107. So anything that is started, the patient has started losing from the baseline in excess of 5 microns would be something which you would be seriously considering as progression, irrespective of what the visual field is showing you, considering that you have followed all the criteria of imaging rigidly. Now, let us take 4 prototype case scenarios, how you can use them, and where you could use the OCT alone for decision making. These case scenarios are very, very common that occur in common clinical practice, because many patients, around 10 to 30% of the patients cannot perform good visual fields or reproducible visual fields all the time. So this case scenario 1, the patient is not regular with follow-up. He may have an irregular dosing schedule. If you see the disc photo here in 2015, discs look approximately the same, but if you see the average NFL thickness, it has reduced from 94 to 79. Considering excellent segmentation, good imaging scores, you would give a lot of importance to this kind of imaging change. And you have here, you have the fields which are absolutely normal from 13 to 15. Now, this is a change where you have almost a lot of progression in the green, followed by just something which is stepping into the pre-perimetric glaucoma range. But here you can see the fields are completely normal. This kind of patient, you would definitely change your method of treatment, irrespective of what anybody might say, because it is definitely much more above the usual expected standard deviation of imaging in such instruments. So would you modify OCT treatment based on OCT in this case? Definitely the answer is a resounding yes. Now, scenario 2, a patient is very bad with fields, and here you have, it's because it's a subjective test, difficulty in fields is very common. Now, if you can see here, there's a lot of fluctuation. Patient is not able to do the test properly. Here, it being an objective test, imaging scores being very high, you can get a very, very reproducible change over time. And you can see that one part, that is the superiotemporal part, has started thinning. And this patient was a case of angle closure glaucoma, who was sensitive to all medications. So she couldn't be put on any medications. And because of the angle closure, SLT could not be done. The patient's pressures were not very high. Baseline pressures were around 18, 19. But once we did the cataract surgery, the angle opened up and the progression literally stopped. You can see absolutely reproducible figures from September 17 to August 2018. There is absolutely no change. But before that, there had been a change of around 5 microns from the baseline to the place where the progression took place locally. Now, here again, you have a patient with severe fluctuation in visual fields. Now, you can see this is not a very uncommon picture in the GPA. Now, what do you make of it? Whether you should give it importance or not? And you are really perplexed, and you can't tell the patient any one direction in which we should proceed. So, in these cases, if you have got an excellent imaging tool, you can see from imaging from 17 through 19. There is absolutely steady RNFL profile. There is absolutely no change or hardly any change to make a statistical difference. And such cases can definitely tell you that with confidence that all this can be ignored, and basically you can continue the patient with the same treatment and follow him more purposefully by using the OCT also. So this is a scenario 3 where you have severe tilted discs. Now, myopic discs do give you their own problems in imaging, but where the imaging can be done with a circle of measurement outside the area of peripapillary atrophy or the staphyloma, you can get reasonably good measurements which are reproducible over time. Here, you can see the posterior vitreous phase. So anything like a PVD changing the profile also you can easily make out in good imaging techniques. Even in these cases where tilted discs and staphylomas, you do get scotomas which are related to the disc tilt. There is no such question here. Whatever the profile will be the profile available to you, and over a period of time you can see that these are reproducible from 2011 through 2016. So such patients who have been initially treated as glaucoma because of some visual field defect, you need not bother, because all these will definitely give you the confidence to say that the patient is stable and the changing field defects might be just a fluctuation. You can definitely treat them on the basis of OCT when you take it in conjunction with risk factors and clinical examination. So now the last scenario here is you have ocular hypertension under treatment with well-controlled IOP and normal and reliable fields. Average RNFL shows decline. Now a very important thing is the quality scores are uniform and the RNFL decline is less than 5 microns. Now having said that, if the imaging the standard deviation of the imaging is around 5 microns, anything that is playing less than 5 microns, unless I have a significant risk factor that is associated, or if the patient is one-eyed or something like that, with some things that we need to consider in addition purely to the imaging or the fields, then I would think about tampering with treatment. But most of the time, with such narrow differences, you wouldn't tinker with the treatment only on basis of imaging. So judicious use involves decision making by using the right technology in the right way. So in such cases where you do not have a gross change or just a borderline change in a retinal nerve fiber layer, unless there are another associated factors or other structural abnormalities in the disc margin or in the macula which is starkly telling you a unidirectional change, you wouldn't change treatment just on the basis of a few micron changes in the imaging technique. Having said that, always make sure that the imaging quality scores are uniform, the images are reproducibly taken, and the segmentation is very good before making a decision in such cases. So take home message is keep it strict. You have to know where to use, which machine to use, and how to use it. Keep it simple with the imaging frequency and reproducible technique of measurement. Remember that a classical change is expected across the diverse glaucoma spectrum. Looking at the whole neuron helps differentiate classical glaucoma from non-glaucomatous optic neuropathy, and use judiciously with clinical correlation, keeping in mind the normal variation and the media changes that can affect imaging. Thank you for your patient hearing. I'm open to questions at the end of the session. Now we welcome Professor Edward. He's a noted international faculty and we are just waiting to hear from him. So I shift the mic to you.
I guess I need to share my screen, right? You need to let me make me co-host, or
yeah, just let me give you a brief introduction of the professor. Thank you, Dr. Sachin, for the wonderful presentation. That was you had given very good practical tips about the OCT. So let me introduce our special guest today, Professor Deepak Edward. It's my pleasure and privilege to introduce you, sir. Just a short introduction about him, because he has so many things to tell about him, but I would just tell a few of them. He is the Vice Chair of Education and Professor of Ophthalmology and Pathology at the University of Illinois. He is an adjunct professor at Wilmer Eye Institute and also Johns Hopkins University School of Medicine, Baltimore, USA. He has been listed in the best doctors in America list for many years. He has over 200 publications and authored chapters in several well-known books. He has been awarded several awards and orations during his career, including ARVO Fellowship, Senior Achievement Award of AAO, and Lifetime Teaching Award at the University of Illinois. So it's a pride and privilege for us to have you here, sir. So today he'll be talking about 20/20 and 10 degrees of visual field. So he'll be giving us all those practical tips for managing our glaucoma patients, with severe defects. So over to you, sir.
Thank you. Okay, let me get my presentation up. So are you able to see my screen or?
Yes.
Okay, let me just, I think.
It's not.
Yeah, is that better now?
Yeah.
Yeah, we can see it.
Okay, wonderful. Well, thank you all for inviting me to give this talk early in the morning here in Chicago. And I enjoyed the previous two talks by both Dr. Deshpande and Dr. Dharwadkar. Very nice talks on OCT and management of glaucoma. So I'm going to address another different aspect of glaucoma, which not many people like to take care of these patients. People with severe glaucoma, severe visual field loss. Speak to you a little bit about how I approach these patients. So this is a beautiful time of the year here in the Midwest in Chicago. The fall leaves changing color. Yesterday was Halloween. This is the picture to the right is specifically for Dr. Natarajan and for others, created by a very talented ophthalmology resident, carving out a pumpkin, showing the back of the eye. So enjoy that photograph. So let's move on to the talk itself. So here's a typical patient with this kind of scenario, a 54-year-old female, difficulty in seeing at night, complaints of glare, things getting worse. Vision is 20/30 and 20/40, intraocular pressures 17 millimeters and 3 medications. And then you can see on a Goldman visual field, a large temporal island in one eye and a central island with split fixation. And on a 10-2 visual field, a central island. So what do you do with a patient like this when you see them the first time? So we'll touch on various nuances in this scenario throughout this talk. So this type of glaucoma, or severe glaucoma, is somewhat of an enigma to many physicians and those who take care. It's difficult to define, it's difficult to monitor, and of course the stakes are high in this type of glaucoma. So we're going to talk about what is severe glaucoma, the challenges surrounding severe glaucoma, how do you take history, how do you take vision, how do you take intraocular pressure and other things. So these all seem like mundane things, but on the other hand, they're important and you have to sort of change your approach a little bit when you deal with patients with such severe disease. So what is severe glaucoma? Some people say, well, I know it when I see it, like the picture you saw with a patient with a very severe visual field loss. The Advanced Glaucoma Intervention Treatment Study defined glaucoma, severe glaucoma, is that one that cannot be controlled by medical therapy alone, and in which there has been some visual field loss with a mean deviation of at least minus 10 decibels. So we don't really use this definition more often, but more commonly use the definition created by Hodap and Anderson Parrish, where the visual field, global loss of visual field is greater than minus 12 decibels, or a field that involves 5 degrees of the central visual field in 4 para-central locations in the 24-2 grid. And I'll show you some examples of that. So here's another field, doesn't look too bad, but you can see these points that involve the central grid. And according to the Hodap-Anderson criteria, this would be a severe visual field loss. So here you see, again, a large degree of hemifield loss, but you also start to see early loss in the second or the inferior visual field. This becomes much easier. Central points start to be involved, and also the inferior field is involved here. I'm sure all of you have seen these sort of visual fields where you have this severe visual field depression, and which does not show up on the pattern standard deviation plot. And I'll talk more about this kind of visual field a little bit later. So why do we worry about these patients? So at the time of diagnosis, many patients may not be functionally impaired in at least one eye, but having more severe visual field loss at baseline is associated with greater visual field loss, or risk of future visual field progression. So This is, I think, something that worries everybody, that you see if someone with a central island and you're worried that visual field progression will get worse and these patients will go blind. So having more severe glaucoma at baseline also increases the likelihood of more rapid progression, not just progression, but rapid progression. So the odds of visual field deterioration are accelerated by approximately 11% for every 1 decibel worsening of visual field at baseline. So 1 in 10%, 1 in 10 patients, and 1 in 10 likelihood of the visual field getting worse. It's not too bad, but the risk is greater than somebody with mild to moderate glaucoma. There's approximately a 23% increase in faster component of visual field progression for each log 0.1 unit of increase in baseline cup to disc ratio. So to practically point this out, someone with a 0.8 cup or a 0.9 cup versus a 0.5 cup or a 0.84 cup versus 8.5 cup would be at a greater risk of developing greater visual field progression. So the take-home points really about with this ominous message is that patients with severe glaucoma are more likely to transition to functional visual field defects, more progression of visual field loss, and more rapid progression. So the stakes are high. Most patients that go blind, again, from glaucoma had severe visual field loss at the time of the diagnosis. So if you look at this paper, again, this came out of the Mayo Clinic several years ago, in a very nice practice, a very well-known practice, in 34 years, under very good doctors' clocks, 56% of 56 out of 290 eyes of patients progressed to blindness. So now, is the reverse true? And this is what I want to emphasize, that most, that even the question we are asking is, do most patients with severe visual field loss go blind? And the good news is the answer is no. So most patients with severe or end-stage disease, and this is a very nice paper, I think would encourage you to read this. Patients with follow-up to up to 8 years, only 10% of patients progress to visual field visual acuities of 2200 or worse, or lost 3 decibels in the mean deviation. And so this, in a practice where you're taking good care of patients with severe glaucoma, this is probably a more realistic figure, despite all the warnings. So the previous slides basically showed you that the stakes are high, that there is a risk. But I think if you take good care of these patients, most of them will do fine over a lifetime of the disease. So what are the functional type impairments that you will see from asymptomatic disease to one causing increased functional defects? So the functional impairments include a risk for falls, accidents, motor vehicle accidents. In the US especially, there's a stigma and challenges regarding driving restrictions. Patients don't like it when you fill out those driving forms. There are social economic challenges, as under unemployment, health case challenges, loss of independence, and of course, a wide variety of mental health issues, including fear, vision loss, anxiety, depression, and patients often get dependent on different types of chemicals, alcohol, to ease their fears and anxiety. So how do you evaluate, how do you monitor, and how do you manage these patients? So on an initial visit, I think you evaluate the patient, and with the asking histories for usual glaucoma risk factors. I think you need to become a real doctor here also and look for other risk factors, especially in patients who have maybe normal pressure glaucoma. I also ask these questions in patients who have severe glaucoma. They come to me usually on multiple medications. You want to get a history of hypotension, which increases the risk of visual field loss, Raynaud's phenomena, which is more associated with low tension glaucoma, sleep apnea, blood pressure meds, especially those that are being taken at night. Patients might state that their blood pressure is excellent, but you need to ask the actual figures. blood pressure measurements at night often compromise circulation to the optic nerve at night, as was previously pointed out. And also other types of activities such as yoga, standing on the head, increases intraocular pressure. Wind blowing instruments, I think, are something that you want to know if the patient is playing those, because that can cause extreme elevations of IOP by increasing jugular vein pressures and chest compression. The type of diet, patients use all kinds of interesting diets when they have severe glaucoma. Family history, if you look at the studies itself, the association, other than in siblings, of glaucoma progression is low, but very often in patients with severe glaucoma, you will get anecdotal history of somebody in the family going blind, and I think you need to take that seriously. On follow-up visits, again, visual history is important. You address complaints. I think you have to listen to these patients with severe glaucoma a little more carefully, because as you will see, that the testing that we do has its limitations, and history becomes very important, as we'll see. You want to also reconcile other history that you take at the initial visit at least once a year, and if not, at every visit. Visual acuity measurement becomes important in these patients. And of course, if you're taking Snellen acuity, you want to record vision in numerical manners, even if the vision is worse than 2400 in some of these severe patients. I know we are talking about a scenario of 20/20, but you will have patients who have 660 or worse vision. And I think having the patient come closer to the chart, having the patient having single optotypes, which are large, which measure visual acuities worse than 2400, are nice to have in the clinic for two reasons. You have a numerical way of measuring it, not just counting fingers at 2 feet or 3 feet. And the second, the patient feels a little better that they're able to see, quote unquote, the chart. It's a little bit more psychologically encouraging. You want to use the same lighting conditions at every time, because changes in lighting in the room, different charts can make a big difference in these patients with markedly constricted visual fields of very severe glaucoma. Now, it's very important to watch the head position in these patients while taking visual acuity. So some of your patients will have large temporal islands through which they can see 2400 or 2200. So they will tilt their head so as to expose their temporal visual field to the chart. So for example, a patient has a right eye severe glaucoma, the patient will turn their head to the left and take and see the chart. So if your technician or someone who's helping you ask the patients to look straight, they will not be able to see those big letters. And this becomes an issue and causes some degree of panic to a doctor. Patient was 2400 at last visit, today it's hand motion. What happened? So sometimes you have to, and I do very frequently, just recheck the vision myself. And more importantly, just ask the patient, have things gotten worse or are they the same? And I would say 9 times out of 10, patient will say everything is the same. The technician did not take the vision the right way. Another pearl I'd like to share with you is that very small media opacities make a huge difference in the quality of vision in these patients. Patients who have 20/20 vision or 20 or whatever level of vision, you might have a small corneal scar that's recent, or more commonly, mild posterior capsular opacification, or some other stuff going on in the media that makes a difference. And the patients will complain bitterly of changes. A little bit change in refraction, a little bit nuclear sclerosis makes a huge change in the vision. So I learned this from the retina folks, especially from patients who have severe retinitis pigmentosa. You have someone with a mild capsular opacification, they're complaining of decrease in vision. Their vision on the chart is still the same. You do the YAG capsulotomy, and all of a sudden, the patient tells you that their vision is back to where it was before. So keep this in mind while assessing your patient. The actual numbers on the chart may not change, but the quality of vision will change. So coming to the actual assessment of glaucoma, so the first is the disc. I think we very nicely heard a comprehensive view of how the OCT is used in in glaucoma. But in severe glaucoma, disc photographs, OCTs are not very helpful, because when you have cups that are 0.9 or 0.85 or 0.8, the change is very hard to determine whether this includes the cupping as well as the rim change. So I really don't do photographs, order disc photographs in patients who have very severe glaucoma. How about the RNF analyzers or disc analyzers? So as we very elegantly heard, that these instruments are highly sensitive in detecting disease, but they are probably more useful in early disease to determine progression, or from progression to normal to glaucoma. In severe glaucoma, the use of these machines is somewhat limited, as very, again, nicely pointed out. There is a flooring effect where there is only that much of the thickness of the retinal nerve fiber layer, which is also consists of astrocytes and extracellular matrix. The nerve fiber layer will thin out, as you see in this particular patient with severe visual field loss till 2020. But you can see the marked loss, and you can't really tell the difference between this and further nerve fiber layer loss in a retinal nerve fiber layer, circular retinal nerve fiber layer scan. So it basically hits the floor. So which eye here is NLP? Can you hard to guess from this picture? So you can see the right eye here was NLP and the left eye is 2200. Again, the OCT doesn't give you much information. Now, there may be some benefit of the macular scan, as was pointed out before. Remember, the macula contains about 50 to 60% of the ganglion cells in the retina. It is about 4 to 5 layers in thickness. So looking at these scans on a qualitative basis, and I say qualitative is that you eyeball it, because the progressor analysis for macular scans in severe glaucoma are not very well validated. So you sort of have to look at it to see if there are changes that occur in the visual, in the OCT thickness in the macula. It's somewhat helpful. There are papers out there. I do use it in patients. It helps me add more information to the visual field testing that is done in the patient. And as pointed out before, there are some patients who can't do visual fields very well. This provides an additional complement to visual field testing. So in summary, OCT photographs are not very helpful in managing end-stage glaucoma. Keep the macular OCT, the RGC layer scans, hold some promises, still needs to be validated, but you can use it to complement your visual field testing. So perimetry, again, to emphasize, is really the mainstay for following patients with severe glaucoma. But there are unique problems in patients with severe glaucoma and visual fields, and point some of those out to you. So the 24-2 size 3 object is not very helpful in severe disease because very often there's increased number of false negative errors. There's a great degree of variability. There's limited patient cooperation, increased fixation losses. The indices might be misleading, and the resolution of the central field is very not good, and there are very few points to follow. Having said that, if someone has good vision and a large central island, this is something that you may want to do if you have good baselines from several years ago. So I've had patients who have had a large central island, very reliable fields. I followed them for 15 or 20 years. Most of their fields are 24- size 3. Occasionally, I will test the central field. There's a newer visual field test available. I think it's called the 24-2C3, where it has visual field testing in the 24-2 area, but there are additional points available in the central visual field where it can monitor the central field. So I think upgrades of your Humphrey machines have this parameter available for visual field testing. came out about a year and a half ago, I think, in the US. We've had it. I've not used it that often, and I'll tell you why in just a minute. So here, this kind of field, doing a 24-2, here's a patient who's 20/20. I saw recently, and this is not very helpful. Again, the central field is markedly depressed, the peripheral field is markedly depressed, and you really don't see the pattern deviation. And doing fields over a period of time in a patient like this is not very useful. You'll see the mean deviation, you might see some fluctuation in the mean deviation and the pattern standard deviation. The visual field indices might change or may not change, but overall, it's not that useful, or not, you can't follow the patients very carefully using this strategy of field testing. So other options available to you are 24-2 using the size 5 object, or 10-2, the size 3 and size 5 objects, the macular threshold, and of course the Goldman visual field, which is not very readily available, and you don't have good technicians. So a 24-2 size 5 object is useful in patients where there's very severe visual field loss and poor vision. So for example, someone is 2200 or 2100, you can test the visual field. It gives you an idea of what the visual field is doing. It's a longer test and may be subject to increased errors, but there's less variability than the size 3 target. And if you have a patient with a central island and a large temporal island, this might be a more visual, more useful in these patients if you don't have a Goldman visual field available to do that. Let's see, let me go back. So many of these patients with small central islands, the 10 degree field or the 10-2 visual field is probably a better field to follow these patients. It increases the number of locations that can be monitored in the central visual field. It has a 2 degree resolution. And the downside to it, is the test is fairly long. It does not have the CETA algorithm built into this testing strategy. So here's a 10-2 size 3 visual field. You can see that the time duration is about 9 minutes, so it's a long test. You have many more test points. It does have visual field indices available. And once the patient gets used to doing this kind of visual field, it becomes a pretty good test to monitor these patients. Here's a patient again who's had severe visual field loss. That's his 24-2 size 3. Here's the 10-2 size 3 visual field in the same patient, showing you how you can monitor the central points of visual field loss and change here, because that's what really want to monitor in these patients. So this is the time of switch. Some doctors or some glaucoma specialists will order both these visual fields in a staggering fashion. I do this in some patients, but often it becomes an issue of insurance. In the US, unless you really justify it, insurance will not pay for more than one visual field a year. For severe fields, you have to provide specific justification why patients need more than one visual field a year. This is the criteria much easier in Europe, where the payer system is a national healthcare insurance system. Now, what about the size 5 visual target? The size 5 target is an excellent test for patients with central islands, even those with severe visual field loss or fixation loss. There's less variability in severe glaucoma. And the size 3 target to the size 5 increases the target size area by about 16 times. There's an increased dynamic range, meaning there's more steps in the testing, so it's much longer test, and the variability is decreased. Now, this visual field testing does not have indices or statistical indices. You need to look at what are known as the quad totals to determine change. So here's an example of a field like this. So here's a patient on your left has had a stimulus 3 10-2 size 3 field, and you can see that the field is getting really bad. And here is a 10-2 size 5 visual field test. Notice that the test duration time is about 13 minutes, and gives you what are called the quad totals. It basically sums up the number of the decibel quantification in each quadrant, and if there is change in any quadrant, you'll see decrease in this number in each quadrant. So you kind of have to manually look at this. Newer electronic medical health record systems such as the Epic, you can enter these numbers in them. It becomes easier for you to follow this field over time, but it is an additional task to do. There are no indices to follow these patients. So here's a patient, again, just showing you how one is following a patient with 10-2 size 3 visual fields over time. Again, very stable patient, but you can see that this is how you want to follow these patients. The other thing that I want to point out is that in these patients who have very severe visual field loss, there can be quite a bit of variability. So you can see how the field gets a little darker, more lighter, again becomes lighter. So there is variability, and especially if you see worsening of the visual field, you really want to repeat it, especially if you're going to intervene or make some sort of surgical intervention or other kinds of intervention to further lower the intraocular pressure. So like I said before, indices are not available. It's sort of a manual judge in these size 5 stimuli. Now, you can also have, there's another field test you can do, which is not usually used, and I've used it on a few occasions, where you do the macular threshold test. This is for about 5 degrees of visual field remaining, and it gives you a gross estimation of the visual field loss. Most of your machines have it, but you don't really look at it. And here's a patient we've looked at over years. Here are the Humphrey visual fields, the 24-2, the 10-2, and there's absolutely no information. The 10-2, this 5-degree macular threshold test gives you some information of what's happening to this particular patient. Goldman fields are nice, but of course, there's it's dependent on whether you have it in your office. Some of the newer machines have this, the ones by Hogstrite have this incorporated as part of the testing strategy. There, of course, is a qualitative degree to this, but the most importantly, you really need to have a good perimetrist who understands the test. Otherwise, it's a useless test. So here you see a patient with a central island and a large temporal island in the periphery. And in your in your Humphrey visual fields, you're really measuring only this. You're missing out on this visual field. Is that important? Maybe yes, maybe no. But this is what's responsible for acuity. And I think that's what you really want to measure. So how often should you perform visual fields? So as I was pointed out before, you need several fields to measure, to determine baseline. Sometimes we have the luxury of doing that, and sometimes we don't. In a referral practice like mine, we often see patients who had all of that done elsewhere. Sometimes we have, and sometimes we don't have the medical records. But I think with severe glaucoma, the kinds of patients I show you, I think you want to monitor them at least twice a year. Things change, and especially when the visual field is involved in the central location, stakes are high, and you want to be monitoring them soon. Patients who are unstable, I think, probably need to be monitored at least twice a year. So how do you judge progression in these patients? So in patients who have OCT as well as Humphreys and mild to moderate glaucoma, they're very nicely set criteria. You have very good progressor type analysis tools which will judge event change or will judge trend change. The rates in severe glaucoma, these progressor analysis tools don't work very well. So we hope that in the age of AI, and there are a number of people working on this, that tools that are newly developed to help this very vulnerable group of patients will help us better in understanding how to determine the rate of progression. But having said that, we can't wait. We have all these patients in our offices with these bad fields. So you have so-called fast progressors and slow progressors. So patients who progress fast account for about 3 to 19% of your patients with severe glaucoma. And what do I mean by fast progressors? Someone who progresses, again, the definition is vague, but for me, someone who progresses more than 2 decibels in 1 year is a fast progressor. So those are the patients you need to watch very carefully. But the question is, even before you reach to that stage, how can you determine or understand who are the eyes or which are the eyes of patients who are at a greater risk of high progressions? So certain categories of patients, for example, of course, patients with pseudoexfoliation are at a higher risk of faster progression. Patients who are high myopes are at a higher rate of progression, a rate of risk of faster progression. Those who had higher baseline IOPs, who have greater fluctuation of IOPs, and of course, those who are poorly compliant or who don't understand the seriousness of the disease, these are all eyes that are greater risk of greater progression. So what do you do for these patients? Of course, you monitor them more carefully, the more aggressive, and most often you end up doing surgery in these patients in order to lower the intraocular pressure goal or to achieve the goal what you want. Now, also, I want you to understand with these severe patients with severe glaucoma, there's considerable amount of noise and fluctuation in visual field testing. So often you have to repeat tests to make sure that the test, what you're seeing, is a true change before you completely change your drug regimen or you do surgeries trying to achieve intraocular pressures in the low teens or even in the single digits. So you need to be careful and not hesitate to repeat visual fields to make sure that there is actually progression in your fields. So remember, most patients will progress at a very slow rate, maybe less than 0.5 decibels a year. Another pearl I'd like you to share with you is that in your office, you get lost in the forest if you don't look at the trees. And what do I mean by that? You're looking at visual fields. It's a busy office, and you look at only the last 2 fields. I think at least once a year, if not every once in 2 years, I think it's nice for you to look at the first visual field you got done for these patients and see how things have gone. And sometimes I'm surprised as well that how badly the patient has done under my clock, that things have changed. I have not realized it because I've just looked at the previous visual field of 2 fields before and not paid attention to what has happened over time. So here's a patient. Again, visual acuity in these patients become an important way to look at the visual field deterioration. Here you see a patient in 2001 with 20/40 vision. Vision is getting worse. The field has changed, it's fluctuating, but things have gotten worse. So if you look carefully at visual acuity charts and how visual acuity it is, talk to the patient, you will see how things may or may not get worse under your clock. So pay attention to visual acuity, even small changes in your office. So I like to call it the how are you doing test. So ask the patient how they're doing. Is their vision getting worse? What's happening with the quality of their vision? And often that'll give you a clue as to what's happening. So in summary, perimetry remains the mainstay for monitoring this disease. Imaging hits the floor. You can monitor central visual field by 10 degree or 5 degree with large targets. And don't forget to ask the patient how you're doing. So what's the IOP range or goal? So of course, in these patients, as previously pointed out, you want a IOP goal in the low teens. Many studies have shown that if you can maintain the intraocular pressure in the low to mid-teens in these patients with severe visual field loss, that you can halt or you can the progression of visual field loss over many years. But having said that, don't chase after numbers. So if the pressure is 15 today and 14 today and 16 on one visit, don't panic. Don't make the patient panic. Bring the patient back for a visual field IOP test. Remember, these patients have very limited visual fields. They have a hard time putting drops in. They might have missed something. There are all sorts of statistical issues that cause the variation in the IOP measurements we don't have time to talk about. Also, remember, there's an error in your machine of ±2. Also, again, medication compliance is something that you really want to explore, ask open-ended questions. And then if you want to achieve your intraocular pressure goal, you have lots of tools available, such as lasers, which are not very helpful, but surgery often is the way you want to go. So this is a kind of a busy chart. I can share this with you later. This is how I think when you have a patient who comes in with severe glaucoma, with low intraocular pressures in the office, but with severe visual field progression. So you look at visual fields, you look at IOP criteria, and look for external criteria that might have changed the visual field, such as retinal problems and CNS problems. But I'm going to leave this here because I think otherwise we probably don't have the time to go over that. So in terms of trying to lower the intraocular pressure in a meaningful way to the low digits, if medications can't do that and the visual fields are progressing, I think trabeculectomy is probably the surgical procedure of choice. Shunts, again, with medications probably can get you down there. I think you probably have to be somewhat daring in these patients where if you have sutures, you probably want to laser suturelize them, or suture. If you have releasable sutures in the trabeculective flap, you want to pull them down early. Sometimes you have to deal with a shallow chamber. Paul Lichter, who's a very famous retired glaucoma specialist, he said, Deepak, you do really need to see a shallow chamber and a pressure of 4 with choroidals in the early course of glaucoma, a patient with severe glaucoma, if you want to achieve single-digit IOPs, and I think is true. Also, in these patients, make sure you, again, monitor their blood pressure history, systemic medication history. And then we come to the subject of neuroprotection. Is there something called neuroprotection or not? And this is an area which has been explored, but there is no definite answer. A lot of your patients will ask you about alternate therapies, So long story short, there really is no clear evidence-based literature to suggest that any of these medications really do help. There are small studies suggesting that medications such as ginkgo, vitamin B3, and a medication known as citicoline, which is again reduces stress response, can protect the ganglion cells. So do I prescribe these medications to the patients? Someone with severe visual field loss was very anxious. We know that many of these have no harm, but if you're going to advise the patients, you really need to understand the dosage, make sure that you give them the right dose. Bob Rich, who is a glaucoma specialist in New York City, is a big proponent of this. He actually formed a company which provides a drug called glaucocetine, which has a smorgasbord of medications available in that. And patients here are clinging for hope. So as long as I think you do no harm, you have something to give to the patient. I don't know if it's a placebo effect or a real effect. It's something to offer them for them as a hope. So, but if you're going to prescribe, understand your medications, understand what they do, understand drug interactions before you embark on providing alternate therapies to your patients. So what about the wipeout phenomenon in these patients? So I'll make the long story short again, that this is an extremely rare phenomenon. It happens. So don't be scared to operate on a patient with severe glaucoma. Their vision will go down in the immediate post-op period. And I would say 98, 99% of their vision will come back after maybe a month, maybe 6 weeks. There are several precautions you want to take. I don't think we have the time to talk about that when you operate on these patients. The main thing is you want to make sure in the perioperative period, you don't give that eye a chance to have high intraocular pressure. So be very judicious with the retrobulbar block, or even give general anesthesia, more peribulbar block, or infiltration anesthesia. That's what I do in most of these patients. I don't give them a block. Monitor their pressure in the immediate post-op period to make sure that they don't have a pressure spike, and watch them very, very carefully in the post-op period. Most of the visual acuity loss is due to your tight sutures for the closure of the conjunctiva. Remember, I said a small change in anything in the media, a small astigmatism created in these patients will drop their vision from 20/20 to 24 or 100 or counting fingers, and we panic. Most of these patients, the vision comes back. So I'll leave that message with you on that. So there are a number of patient concerns. You know, they're 20/20, they complain they can't see, they have glare. And the phenomena of glare that they describe to you is really a loss in contrast sensitivity. Everything is washed out. Patients, especially who go to the grocery store where there are bright fluorescent lights, they can't see anything. They can't see the labels in the store on the things that they're trying to buy. So simple measures such as a brimmed hat, the hat with the visor, will cut out some of this light and glare and improve their vision quality much better. Fishing glasses, something with an orange tinge, which takes out the glare in the orange spectrum. Patients appreciate that. Again, not dark orange, but light orange is helpful. Don't be, ask the patient of what the visual needs are. Low vision aids can be helpful. Newer computers are very useful for these patients. Support groups, again, be an advocate for your patient. At the end of the day, the patient doesn't care much about his intraocular pressure or his visual field. He's concerned about what he or she is seeing, how he or she is living in their little microenvironment within their homes. So if you're able to address that, you'll have a very grateful patient. So in conclusion, most patients with severe glaucoma are going to do fine. That's the good message. But you really need to modify your approach on how you approach these patients. You need to be careful as you look at them, modify your approach. You need to be curious about, what I mean by curious is you need to really mentally think on how to deal with these patients, how to deal with progression, to figure out if there's really progression. You need to be caring for these patients. Make sure you understand that you care, to show that you do care about them, and provide them not just care, but compassionate care. And you'll have patients who are grateful for what you're doing to them. Of course, the wow effect is not there, like you see in a cataract surgery, where a patient who has a white cataract goes from hand motion to 20/20, and you see that sparkle in his eye. You don't see that in these patients, but you will have quiet gratitude from these patients who have a very difficult disease. So thank you very much for your attention. I think I've gone a little bit over time. Sorry about that, but I hope this was a useful talk.
Thank you very much, sir. That was a wonderful talk. All the practical aspects, especially, you have covered. These patients are very difficult to treat and to tackle. Actually, it's very difficult for us to say. It's very easy for us to say, that nothing can be done about this because your vision is very, very low. And it takes a great effort, not just from the patient, but also from the doctor to, take notice of all the difficulties that this patient is having, and to help him practically to solve those difficulties, and to maintain, most importantly, maintain his vision, whatever it may be, to maintain it throughout. So at least he has some useful vision left. So thanks a lot, sir. Please send in your questions. We are ready for the questions. Please type it in, and we'll be very happy to answer it for you. Dr. Sachin, any points for discussion you want to have?
Yeah, Professor, good evening. That was a very enlightening talk from you. So I would like to ask you a couple of questions regarding this. As you rightly said, in these cases, even a small amount of media opacity makes a lot of difference in their quality of life as well as their functionality. So when we are trying to do cataract surgery in such cases with advanced visual fields, are there any special precautions that you would like to tell us?
So you bring up a good point. So cataract surgery or even glaucoma surgery. So if you're just doing cataract surgery, I think one is, I think topical anesthesia is something you want to do and not give a block. if you give a block and you probably don't want to do too much of massage on the eye. Sometimes if I have the luxury, and these are often older patients, if I can give general anesthesia, I'm not hesitant to do that if I need to do it, especially monocular patients. I will also make sure that after the cataract's done, try to keep the bottle height low as possible. The newer machines have, the ability to actually control the intraocular pressure during surgery. Also, very good cleaning of viscoelastic in the eye. If you're doing that, make sure you get the viscoelastic out so that you don't have a pressure spike. Now, most of these patients, when I operate, do just cataract surgery. I'll do them the first thing in the morning, have them sit around till the afternoon, and tell them that I'm going to be checking the intraocular pressure in the afternoon. And you'll be surprised how many people will have an intraocular pressure spike, even in the presence of a trabeculectomy of other procedures. The other additional thing I do, and there's a nice paper for you to read, and I can send you the reference there. I often give them Diamox, these patients, before surgery. So you want to give Diamox about an hour or two before surgery. The greatest effect is somewhere around, now we have, do you have long-acting Diamox available in India, the sequels, or no?
Yes.
Yeah, sequels. So I usually give them sequels, and so it lasts for a bit. And often I'll give them another Diamox sequel at night, even if the intraocular pressures were well controlled in the preoperative period. I do that. So those are some of the precautions I take. Intraoperatively, you want to make sure the pressure is not high. Postoperatively, check the pressure. Make sure you clean viscoelastic well, and those are the kind of precautions I take. And it's very similar in trabeculectomies in these patients. You want to make sure that they don't have a spike. One patient that I had lost fixation in several years ago, I recall, the patient had a pressure spike of 50, and basically went from 2030 to 2200. Most of the patients with the trabeculectomy and other techniques we have today, they don't lose fixation. The wipeout phenomena is very, very rare, but it is something of concern. I discuss it with the patients that it is a possibility, even if the risk is low. So the stakes are high, but I think you have to deal with it when you have to deal with it.
So, sir, do you prefer to keep such patients on maximum medical therapy along with the oral Diamox for a long time?
It depends. It depends. So, for example, a good point. So if the patient was previously on 2 drops, you've done a trab in the past, or a tube. Tube has become a fashion in the United States. I'm one of those dinosaurs who still does trabs. These are patients not for mixed type procedures. So if they were on medications, the answer is yes. If I did topical cataract surgery, I'll have them start the medications on the same day, including the antibiotic and steroid, and put them back on their drops immediately. So the short answer is yes.
Okay. And
now, as we know that intraocular pressure does come down after cataract surgery, so I think that algorithm is more for patients with mild or moderate glaucoma. Remember, these patients, their meshwork is probably completely shot, and I don't think it makes much of a difference of cataract surgery lowering intraocular pressure in these patients with severe glaucoma. I don't think we should be thinking about that in these patients.
Okay, so classically, when will you operate those patients, like doing a trab or maybe a retrab or putting a tube? So when do you basically feel that the medication is not working and I should go and operate? So what should be that thing that we should keep in mind? When to operate such patients?
So these patients, again, if I have, we're talking about the severe glaucomas, correct?
Yes. Yes.
Yeah. So if I see visual field change, which is confirmed, and I'm sure that there is a change, and I want a lower pressure in these patients, typically, if they've had a previous let's say they had a previous trabeculectomy, okay? In these patients, today, I have the option of putting a Zen implant in there, which would be my procedure of choice in these patients. I give more mitomycin C than I would usually do if the trap had scarred down in another quadrant, and put the Zen in. The goal in the end becomes a procedure where you have pressure lowering with the new surgical procedure plus additional medications. So I tell the patient the surgery is not, you're not going to get rid of your medicines most likely. You're going to get lowering of your intraocular pressure. Think of this as a big drop, another medication which is more effective. So that's my approach. Trabeculectomy is doing a second trabeculectomy in an eye that has a trabeculectomy before. The success rate is not that great, and I'm sure you've had the same experience. Those are the patients I end up doing a Barval type tube or tube, with a large surface area. That approach is also a little tricky, as you know, because you tie the tube off in these patients. These patients can have a pressure spike. Often what I do as a technique is I actually fenestrate the tube with another ninovical suture in the post-op period and put them back on maximal medical therapy till the tube opens up. How do I get pressures in the single digits? It's challenging, honestly. It's easier in a patient who hasn't had a trabeculectomy or a procedure before. I think you can become aggressive, like I said, do a trab and make it almost full thickness earlier on in the post-op period. Take the releasables out soon or suture lies very soon. AC gets a little shallow. You treat them aggressively. You're more likely to get lower IOPs in such a patient. But it's challenging to get a patient. There's no way of controlling on which patient is going to get single-digit pressures or not. Thankfully, again, realistically, there are very, very few patients in my practice over the last 25 years where I had to resort to such aggressive measures. It's rare that you have to do that.
Okay, one more small question first on advanced glaucoma is that nowadays all these modern machines are actually equipped with size 5 stimulus as well as the kinetic perimetry. So when we have a 10-2 size 5 test to fall back on, what is the place for kinetic perimetry in such cases? Do you still end up doing it in some cases, or 10-2 size 5 will solve the problem in most of them?
So, we're blessed with some very good perimetrists. Even now, the automated perimetry, the machines that are available, which have automated kinetic perimetry, I don't find them very reliable. They have their own drawbacks. It's good to do a quick visual field. There's quite a bit of variability, despite what the companies say that it does. We have one machine. We've tried the kinetic in severe glaucoma. Remember, these patients don't have very good fixation. They move around. Unless you have someone monitoring their fixation while they're doing the fields and they know where the previous defects were, you need a good perimetrist. So we are doing fewer. The best perimetrist we have is about to retire. And I think and the ones that are younger don't want to learn how to do that. So we're more and more switching over to the 10- to Humphrey visual fields to follow these patients. So there is a role. I think the key factor is to have an excellent perimetrist who can monitor the automated field while you're doing that. So that's the way I look at it. I rarely use the automated feature.
Okay.
So I can tell you the only place where I really use it is, so in the US, if you have impaired vision, the patients come in and almost on a weekly basis, we have a patient for a renewal of driver's license. They're about 85 years old. They're still driving. They want this field test done. So we only have to test the 5-4E and the 3-4E target. So we put them on the automated machine. They're finished in about 4 to 5 minutes an eye. We're done. And we give them the report. But otherwise, for a high-risk glaucoma patient, we really don't use that.
One last question from my side. You did mention about other risk factors like hypotension and sleep apnea. So, how common are these two factors in your practice? Because out of the recent literature, we have found alarming rise in the incidence of sleep apnea in the general population. So that encompasses those having glaucoma too. So, how far has sleep apnea and hypotension been a part of the risk factors that you get to face in a day-to-day basis?
Excellent question. So, sleep apnea is a big problem. It is a huge problem in our population. And you kind of pick this up and you start asking questions. You have a slightly obese patient, and sometimes you just pull their lids, they're kind of floppy in the clinic. So immediately that alerts you to ask that question. It is an issue. It's a modifiable risk factor, so I pay more close attention to it so that at least they can get their CPAPs and be able to do that. Having said that, I had this patient recently, a disaster, who has sleep apnea, severe glaucoma. I did a barbell shunt on her. Her sleep apnea, the mask slipped over her eye in the post-op period, and basically the whole wound dehisced. Well, that's a side story. But I think that's a modifiable risk factor, and I think it's common. You have to ask the question. People won't volunteer. They might not know that they have sleep apnea. Often, if the spouse is in the room, you can sometimes get the answer, yes, my husband or my wife, they snore, and all of a sudden I feel that they stop breathing. So I think, or you can ask the patient about what their symptoms are, very tired in the morning when they get up. So I think that's something you need to ask. Hypotension, again, one has to understand what is hypotension. What kind of hypotension are we talking about? So we want to look at hypotension where the blood pressure is low enough that might cause hypoperfusion to the optic nerve, right? So it has to be below the mean arterial pressure. It needs to be lower than the intraocular pressure to do that. So you're talking about blood pressures in the diastolic of 50, 40, or 60, and a systolic of 70, 60. And those kind of blood pressures are worrisome. The 100 by 60, 100 by 80, I don't think those are patients who are really hypotensive. Giving hypertensive medications at night, it can be an issue because we don't know what's happening at night. So I think most internists now are aware of that as well. So you don't want to give that at night. Now, is there a study showing that it makes a difference? The answer is no. But it makes practical sense. You can't do a study for everything, right? So we know it's a risk factor. So now, let's say normal tension glaucoma patient does have hypotension, right? Real hypotension. What do you do about it? That's also a very difficult question to answer. So I'll tell you what a lot of people do here. We'll ask them to drink some tomato juice at night, or eat a bag of salty chips. That's basically giving them more sodium at night, hoping they increase their blood pressure. Some physicians will refer them to an internist, and they'll get oral corticosteroids, especially the fluorinated ones. I don't do that myself. I don't feel I have expertise enough to do that. Have I done that in my career? Probably 2 patients, maybe. I've sent them. Did it make a difference? Again, it's anecdotal. These patients lived till their late 80s. They were still staying before they died. So I don't know if it had anything to do with giving them fluorinated corticosteroids, but these are options that are available and kind of makes common sense, but you have to be careful, right? There's a risk versus benefit ratio. And I'd rather have an internist or a cardiovascular doctor take care of it rather than me.
Thanks a lot, Professor.
Yeah, we have some questions here. We'll just take a couple of questions and then we'll stop. Yeah. So, do you make any changes in your operative technique while doing trap in such patients? As far as the technique is concerned for the trap,
Okay.
or it would be the
It's
same as you would be
more
doing.
the perioperative care that I talked about. Giving them Diamox before. If I almost never give a retrobulbar block in these patients. I use a technique, a general anesthesia, if I have the luxury of being able to do that. Or if not, even not a peribulbar block, what I will do is I'll give them some either subtenons anesthesia or just infiltrate anesthesia in the superior subconjunctival quadrant. I sort of judge this preoperatively. The patient's going to be cooperative enough. When I do an iridectomy, I'll inject some 1% lidocaine in the anterior chamber. I'll give them pilocarpine before, because once you give the lidocaine, people start to dilate. It's hard to do the iridectomy. With a combination of so there are two times when the patient has pain when you're doing this. One is when you're opening the conj, so when you anesthetize the conjunctiva well. The second is the cautery. When you're applying that, you got to make sure that the surface is very well anesthetized. And the third placement is when you're doing an iridectomy. So you really want to make sure that they have anesthesia inside the eye. I would say most patients are able to tolerate this pretty well. You don't need to put a traction suture, because the patients will help you infraduct most of the time and be able to look down. And again, you can not patch these patients afterwards. You can just put a shield on them, especially if they're monocular. They're grateful. Even if the vision is blurred, they're able to see that. Post-op, so intraoperatively, I try to tie the sutures loose, and make sure you have more flow than what I usually do. I don't know if any of you use viscoelastic in the anterior chamber while doing traps. I never do. But if you do, I don't think we should be doing that in these patients. And try to also not to keep the chamber maintained during surgery. I think that's important. I know some people use anterior chamber maintainers in Europe. I tried, if you make a high enough sclerostomy into the cornea, often you can keep the chamber quite well maintained when you're putting the sutures. If you do a more posterior sclerostomy, the chamber tends to get flatter easier. So sutures are tied loose, have a very tight conjunctival closure. I use a modified Weiss technique to close the fornix space, continuous running mattress suture at the limbus to close the trap. And post-operatively, I again monitor their pressure a few hours after surgery. So I'll operate on these patients early in the morning so that I can see them in the afternoon or evening before they go home, and give them a Diamox at night. And most patients do fine. So do I use more Mitomycin C to get lower pressures? It varies. In the African-American patients, yes. I tend to use, sometimes 0.4, but my standard dose is 0.3 milligrams per ml of Mitomycin C. I think, again, the high-risk patients with Zen available as an option, it's something that I tend to use. The only issue with the Zen is there's a very high rate of needling. So you have to be ready to do that in the office also, and treat these patients. So that's what I have to say about that.
Okay, so this one is the last one now. We will take one more. What kind of tubes is preferable? Do you do a walled tube like Ahmed, or do you prefer a non-walled tube in such patients?
That's a long answer. So in these severe patients with severe glaucoma, I do either. So I'll give you one scenario. So I'm doing a patient on Wednesday. He's monocular. He has a cataract. He has severe glaucoma. He's deaf. He's 84, and he just got divorced from his wife. So that's another story. So there's a huge compliance issue. I'm not sure if he's going to show back to the office on time. I would not put a Barwelt in this patient. Okay, this is a patient who has a pressure in 20s, and so this is a patient I'd put an Ahmed in. I've told the patient I think you're still going to be on Diamox post-operatively forever till you're alive. and also on multiple medications. But putting a barrel vault in a patient like this, where compliance is an issue, is a recipe for disaster. Having said that, most often I'd use a plate with a larger surface area. So something like a 250 barrel vault. I don't typically like a 350. I know you also have the RD implant available now in India. I think that would be my implant of choice. If I put an implant, I will make sure my preferred way in the post-op period, apart from putting them back on maximal medical therapy and Diamox, is to do a tube penetration with a vicryl suture. So I use Vicryl on a TG needle to close the conj after a shunt. I'll use the same needle to create a fenestration, but leave a wick of Vicryl inside the lumen. So it acts like a wick. So I know when my Vicryl opens up in 6 weeks, this Vicryl will also dissolve and close the fenestration. So what's been my impression of this so far? You end up, if you just do that and give them topical medication, the pressure is often in the high teens in these patients, and they meet a post-operative period most often. And so sometimes I'm able to avoid giving them Diamox. And I found it very useful rather than just making punctures of fenestration in the tube. My experience with fenestrations is I cannot predict what's going to happen. Sometimes I'll see a flat chamber. Sometimes I'll see a pressure of 40. I've stopped doing fenestrations, and this single wick technique, I think it's been well published by a couple of people, is my go-to method when I put a large area shunt in these patients.
So we have a lot of questions here, but I don't think we have time for all of them. So
Okay.
I think we should end the session here. It was wonderful of you to come here. So I would just like to thank some people here because of which, we could have this program. So first of all, thanks Centaur Pharma for arranging and giving us a platform for all this discussion. Thanks to Samir and Dinesh for giving us this technical support and making all the arrangements for this. Also Anil, who has been helping us a lot with this program. We have Dr. Sapna, our anesthetist, Dr. Radhika, who is our medical director, who are always, coordinating things and making things easier for us. My special thanks to you, sir, for, joining us here. Being Sunday morning, early 6 o'clock there, it's
an interesting thing. Actually, today's time change, they've gone, fell back 1 hour back. So it was 5 o'clock in the morning, not 6 o'clock.
Deepak, you're looking fresh for 5 o'clock in the morning.
Yeah, so thanks a lot for coming here and giving us that wonderful talk about about the glaucoma part, which is advanced glaucoma, and giving us all those practical tips here. And last but not the least, thanks Dr. Natarajan. He's always behind us, and he is the driving force, behind all of us. So thanks a lot, all of you, for making.
He's a driving force everywhere.
Yeah. How are you, Deepak?
I'm doing well.
We can see some Chicago through your camera.
I'm freezing here.
Okay.
It's 1.5 degrees centigrade today in the morning, but this is winter, coming about winter in Chicago, so depressing, but what do you do, right? And you can't even travel now.
I know. And how's the COVID situation in Chicago?
Well, it depends on who you talk to. There are more cases, but the deaths are definitely, and hospitalizations are not that much like they were in the first wave. Right. So in my hospital, we're kind of in the epicenter. We really have only 4 patients in the ICU and with COVID, despite the rates going up. Most that are infected are young people. They're going out for parties still. So at our university for the undergrads, we have mandatory testing twice a week for them. Just saliva test that's FDA approved at UIC. I can go at any time and get a test done, and I've done that several times just to make sure. Very high. And what they've found by contact tracing is basically these young folks, they get together in a bar or a party because they're bored, and that's how they get it. Most of them are asymptomatic, they don't know it, and then they go and visit their parents or their grandmother, and that's when trouble starts.
Right. So how will the saliva testing come to India?
I don't know. I mean, it's available. I mean, you have to spit a lot, so you have to be careful. So they ask you not to eat anything for 2 hours or feel a little hungry before you go. And so it's a large amount of saliva that you need. I don't know about how it's going to get to India or not get to India. It's an interesting time. I kind of shut myself from the COVID news. There's way too much going on.
Right.
I think staying practically careful and being common sense is the way to look at things. But
yes.
And of
Deepak,
course,
Deepak, you can stop the sharing the screen so we can see you full screen.
Oh, okay. Let me.
And then in the meantime, Dr. Radhika is requesting the center person to go offline so that we can talk for a few minutes and then you can go. Is it still we are live, Dr. Radhika? So we have to talk. Yeah,
Okay,
we can stop, but we want.
My screen is off now, I think.
Yeah, you can see you full screen now. You can see the UI Health Illinois Eye.
I think Dinesh can stop the live telecast.
And the Zoom can be there for a few minutes, Dinesh. Can somebody call Dinesh?
Okay, hold on. Just give me 2 minutes.
Yeah.
It was here, I think.
But anyhow, we are talking good for the public only. Nothing. What, Deepak?
Yeah,
So,
I mean,
how's your schedule as a glaucoma surgeon in Chicago now?
Yeah, I mean, we are back to full-time care. I mean, we've gone back to what it was, similar to last year.
Okay.
Number of patients and everything else is back to normal. I'm sure you guys are the same.
No, still we are not.
Not?
No, but what do you do as a routine when you go to the hospital? You have an N95?
Yeah, I don't wear an N95. I use an OR mask. We have a high-risk area where patients have tested COVID positive. For that, I wear an N95. In the OR, I don't wear an N95 because all patients are tested right away. They get their test back in 30 minutes. Everybody who, but of course, we have a lot of physicians and nurses and other people there. We don't know their status, so we try to keep doing well. So the test results in the last 90 days